Welcome back to Surgery from SnazzySurgeon. Today we are going to do a deep dive into the Lichtenstein tension-free hernioplasty. I'm excited to have you with me. You're definitely the expert when it comes to hernias.
I appreciate it. Happy to be here.
Um, for our listeners out there, fellow surgeons, you know we're going to unpack the nuances of the Lichtenstein procedure, really just to remind everyone about this foundational technique in hernia repair.
Absolutely.
So we'll consider the indications, anesthesia options. I think there's a lot to be said about patient positioning, and of course, all of those critical operative steps involved in a successful Lichtenstein repair.
Looks forward to diving into it.
Where should we start? I mean, the Lichtenstein procedure. When does it really shine for you?
It's really quite a versatile technique.
Right.
I think its broad applicability is really a major advantage.
Okay.
You can confidently use it for all types of inguinal hernias,
Okay.
whether you're dealing with a direct or an indirect presentation.
And I've got to say, speaking from experience, it seems particularly well suited for those direct inguinal hernias.
I would agree with that.
We see them so often, don't we?
We do. You know, when you encounter that direct hernia and you see that wider defect in the posterior wall of the inguinal canal, the Lichtenstein with its tension-free mesh reinforcement just provides that excellent support and strength in that area.
It's my go-to.
Mine too.
For sure. Absolutely. Now let's talk about some of the options for anesthesia. It's quite a spectrum, isn't it?
Yes, you have several choices ranging from spinal to regional techniques like epidurals. You can also use local infiltration or, of course, general anesthesia.
I'm a big fan, and I think our patients are too, of regional anesthesia, spinal or epidural.
I agree.
Really seems to provide excellent pain control after surgery.
It does. Patients are able to mobilize earlier,
Right.
and they require less analgesia. So, yeah, big advantage there.
I mean, we're also seeing more and more local anesthesia being used, especially for our outpatient procedures.
You're absolutely right, and it's being done safely and effectively in many centers. You know, local infiltration allows for same-day discharge for appropriately selected patients. So in the right setting, that can be very convenient and efficient.
Sure. So when you're considering these various options for Lichtenstein repair, what really guides your decision-making process?
Well, I think ultimately it's a multifaceted decision,
Oh,
and the patient's medical status is a crucial factor.
okay.
Also, patient preference, shared decision-making is important.
Yeah.
And then, of course, you have to take into account the judgment of the surgical team, the anesthesiologist,
Yeah, right.
all working together.
A team effort.
It really is. It's a collaborative assessment to ensure the safest and most comfortable experience for the patient.
Makes a lot of sense. All right, so let's get into, I guess, what everybody considers to be the nuts and bolts, the core of this procedure,
Yeah.
the operative steps. Where do we begin?
Well, the first step, of course, is the incision, the inguinal incision. It usually starts medially at the pubic cubicle and extends laterally beyond the deep inguinal ring.
It's about 2 centimeters above and parallel to the inguinal ligament, correct?
Yeah, 2 centimeters above and parallel. It gives you that nice access to the inguinal canal and allows for clear visualization of the anatomy.
Okay, so after the incision, what's our next critical step?
Next, we need to expose the inguinal canal. We dissect carefully through the subcutaneous tissue layers, campus fascia, and scarpus fascia.
And then,
Once you're through those layers, you'll need to identify and incise the external oblique aponeurosis.
that incision in the external oblique aponeurosis, if I remember correctly, follows the line of our skin incision extending from the superficial inguinal ring all the way to the deep inguinal ring.
That's right, exactly. And that gives you access to those structures within the inguinal canal and brings you closer to the hernia.
Makes sense. And then comes, I think, a step that requires a lot of care and attention, which is identification of those key anatomical structures.
Right.
This is where you need to be extremely meticulous.
Okay.
So you're going to want to identify and preserve the ilioinguinal nerve. You want to avoid damaging that nerve because that can lead to some nasty post-operative pain.
I've seen that. Chronic pain.
That's right.
It's a real problem.
Exactly. Then you'll carefully open the cremasteric muscle and fascia to expose the spermatic cord in males, or the round ligament in females, and of course the hernial sac itself.
So now, how we manage the hernial sac, I guess, depends on the type of hernia, right?
Yeah.
Indirect or direct?
Yeah, that's a good point. Let's start with the indirect hernia.
Okay.
In an indirect hernia, you're going to dissect the sac superiorly all the way up to the deep inguinal ring. You'll open the sac at its fundus, and gently reduce its contents back into the abdomen.
Okay, and then we ligate and excise the sac at the neck.
Great. Transfix and ligate it securely, and then excise the redundant portion.
What about alternatives? There are some for smaller sacs, right? Yeah, for smaller indirect sacs, some surgeons might choose to simply invert the sac into the peritoneal cavity without ligating it.
Makes sense.
It really depends on the size and characteristics of the sac.
Okay. Now what about direct hernias?
So with a direct hernia, the sac protrudes directly through a weak spot in the posterior wall.
Okay.
And you can usually reduce it by applying gentle pressure, just pushing it back into the abdomen.
And if you've got a large direct hernia, what do you do?
If it's a large direct hernia, you might find it helpful to invaginate the sac using sutures.
I do that too. I use an absorbable suture.
We too. Creates a smoother surface for placing the mesh.
Yeah. All right, so now we're at the heart of the Lichtenstein technique, which is placing the mesh.
That's right, the mesh.
Polypropylene mesh.
Yes.
And what size do you typically use?
I usually use a mesh that's about 8 by 15 centimeters.
Okay.
Some surgeons prefer a slightly larger size, like 16 by 10 centimeters.
And why do we make that slit in the mesh on the lateral side?
Ah, the slit. That's to accommodate the spermatic cord as it passes through the internal ring.
So it doesn't compress the cord.
Exactly. Allows the mesh to fit snugly around the cord.
I see. So the mesh is positioned over the entire posterior wall of the inguinal canal.
That's right, behind the spermatic cord.
Okay. And how do you decide on the positioning of those edges?
Well, that's crucial for a successful tension-free repair and to prevent recurrence.
So tell me about it.
Medially, the mesh should overlap the pubic tubercle by about 2 centimeters. Gives you a good anchor point. Laterally, you want it to extend at least 2 centimeters beyond the internal inguinal ring. That way you reinforce that area that's prone to weakness.
Okay. And once we've got the mesh position, the next step is fixation.
Absolutely.
Yep.
For that, we use non-absorbable sutures.
Polypropylene.
Yeah, usually polypropylene size 1 or 2-0.
I like those.
And again, no tension on the mesh.
Right.
That's very important.
So walk me through those suture lines.
Sure. So first, the medial edge of the mesh. You're going to suture that to the tissue over the pubic tubercle and then continue that suture line laterally.
All the way to the inguinal ligament.
Yes, attaching the lower edge of the mesh to the inguinal ligament just past the internal ring. And then there's that second suture line.
I know this one. This one starts at the pubic tubercle as well.
That's right.
Yeah.
And runs laterally, securing the mesh to the internal oblique.
It's about 2 centimeters above the edge of the aponeurosis, if I remember correctly.
Yeah, 2 centimeters. Good memory.
And now we need to deal with those tails of the mesh we created with the slit.
Right. You don't want to forget those tails. So you suture the lower edges of those mesh tails to the inguinal ligament. This creates that new internal ring of mesh around the cord.
And throughout this fixation process, again, tension-free repair.
Always. The mesh has to lie flat and be secure without any pulling.
Absolutely. It's critical.
Okay.
Now we're ready to close.
So you gently place that spermatic cord back into the inguinal canal over the mesh.
Okay. And then we close the external oblique aponeurosis over the cord.
That's right.
I usually use a continuous suture for that.
Sometimes continuous, sometimes interrupted.
Depends on the case.
Yeah, exactly.
All right. And lastly, we close the subcutaneous tissue and skin.
Correct.
I like to use those interrupted monofilament sutures for the skin.
Yeah, they provide a nice closure.
So there we have it. We've gone through the Lichtenstein tension-free hernioplasty step by step.
It's a classic procedure. Really stands the test of time.
It does. It does. And I think this discussion really highlighted those key elements.
Yeah, it's important to understand those steps thoroughly and the rationale behind each one of them.
It leads to successful outcomes.
Absolutely.
It's all about those good outcomes for our patients.
For sure.
Thank you so much for sharing your expertise with us.
It was a pleasure.
Really appreciate it.
Anytime.
And to our listeners, thank you for listening to our podcast. We'll see you next time.